Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I'd like to welcome Dr. Nina Kim back to ECHO. Dr. Kim has joined us before and given talks before, and we'd like to thank her for giving this talk today, the last of our three-part CROI update series. Dr. Kim is Associate Professor of Medicine here and one of the providers at Harborview's Madison Clinic, and I will turn it over to her to give an update on Hep C and co-infection studies from CROI.
Thanks, Brian. Thanks, everyone, for joining in today. So I'm going to go over some of the key hepatitis studies from this year. This was a very exciting session. Both the studies that I'm going to be talking about were part of the Tuesday oral session. So those of you who want to know more details about the study can go onto the CROI webcast and actually see the sessions. This was the Photon-1 study, which this is really the proof of concept study for interferon-free hepatitis C therapy in HIV, Hep C co-infected patients. And as many of you know, sofosbuvir is now on the shelves, out on the market. It is an NS5B nucleotide polymerase inhibitor. It's a chain terminator. And it's nice because one of its advantages is that it has broad antiviral activity against genotypes 1 through 6. It has a high genetic barrier for resistance and has a very nice safety profile. And it did get FDA approved this past December, and the label covered both mono-infected and co-infected patients. And the co-infection label was really based on the Photon-1 data, which they presented the final results of in this session. Basically, the dual therapy regimen of sofosbuvir ribavirin from anywhere from 12 to 24 weeks of duration has been associated with SVR rates of about 68 to 97% in mono-infected patients. So this study design enrolled genotype 1 Hep C naive, treatment-naive patients. This was the largest of the three groups. 114 patients received sofosbuvir and ribavirin dual therapy for 24 weeks. The second arm included genotype 2 and 3 naives. These folks received 12 weeks of sofosbuvir ribavirin dual therapy, and then they had a treatment experience arm of genotype 2 and 3. So they did not actually enroll genotype 1 treatment experienced patients, and they basically presented 24-week SVR data. Patient characteristics, so as you can see in the treatment-naive groups, most of them, as with any of these co-infection studies, were men. What was nice about the treatment-naive genotype 1 arm is that they enrolled almost a third Black patients, most of whom had the less favorable IL-28B genotypes. Only 4% of the genotype 1 naives were actually cirrhotic, and you can see here that there is a higher proportion of cirrhotic patients in the treatment-experienced genotype 2-3 arms, which is not surprising because these are often the folks that are a little less treatment refractory. So these treatment-experienced patients, by the way, were those who had actually failed peg interferon ribavirin therapy. The vast majority of these folks were on antiretroviral therapy, and the regimens that they allowed were basically Truvada plus efavirenz, boosted atazanavir, boosted darunavir, and then raltegravir and rilpivirine. And you can see here that the mean CD4 counts were quite high amongst the participants. This was the SVR24 results, so sustained virologic response 24 weeks post-treatment. And you can see here that in the genotype 1 naive arm, they had an SVR24 of 75%. 75% is a very respectable result. This is really on par with what we get with triple therapy with peg interferon ribavirin and one of the older protease inhibitors, boceprevir or telaprevir. So this is what you're achieving without interferon. And you can see here that in the naive genotype 2 and 3 with 12 weeks of therapy, just as with the mono-infection studies, you see very high SVR rates with genotype 2 naives, a little less so for genotype 3s. And then when you look at the treatment-experienced patients who got 24 weeks of dual therapy, you can see that 24 weeks you achieve very high SVR24 results, 92% among the genotype 2 treatment-experienced folks and 88% among the treatment-experienced genotype 3s. So what was exciting about this session was actually when people saw these results, much of the discussion centered around the fact that HIV as can almost be taken off the table as far as thinking about its impact on treatment outcomes. So that these results are quite comparable to what has been seen among folks who are Hep C mono-infected. In terms of virologic failure, there was no major resistance observed. The vast majority of patients who actually failed to achieve an SVR actually had a viral relapse, meaning they became undetectable, stayed undetectable on treatment, but eventually the virus showed up post-treatment. And the two individuals who actually had evidence of viral breakthrough on treatment, they actually were later found to have undetectable sofosbuvir levels, so clearly didn't appear to be taking the medication. And then the in vitro variant, the S282T, that has been linked with sofosbuvir resistance in vitro were actually not detected among the treated patients. And then the NS5V, they looked at NS5V polymorphisms at baseline, and none of them appeared to confer phenotypic resistance. So really good outcomes there. And then in terms of adverse effects, you can see here, this is kind of splitting apart the folks who got 24 weeks of therapy versus those who got 12 weeks. You could see here that the rate of serious adverse effects was pretty low, and the discontinuation due to adverse effects was on the order of 3 to 4%, which if you compare this to trials that have PEG interferon and ribavirin, this is like much lower. It's typically on the order of like 25% that you can see. And so you can see here that they did see some fatigue, insomnia, headache, which in the end, Susanna Nagy, who presented this data, was saying, she wondered whether a lot of this was related to the ribavirin. And you can see here that you did still see some anemia, although severe anemia was really pretty low incidence. In terms of HIV safety, no one really ran into, so people who actually had detectable HIV viremia on treatment were also documented to have non-adherence to their antiretroviral therapy, and there were only 2 individuals among the treated patients, and there was no decrease in absolute percentage CD4 cell counts, which is really nice, as compared with PEG interferon-based therapies, where we can certainly see declines. This is just a reminder of the fact that like HIV, there are multiple targets within the hepatitis C viral life cycle for therapy. And one of the questions that was asked by a group of investigators at NIH was, if we use multiple direct-acting antivirals targeting different stages of the life cycle, can we actually shorten the duration necessary to achieve an SVR? So they really wanted to push the envelope and see if we can even do therapy as short as 6 weeks. So what they did was they looked at, so they had 3 treatment arms. They enrolled treatment-naive genotype 1 patients who had all stages of fibrosis to what was their standard therapy arm of dual therapy with sofosbuvir plus ladipasvir. So this is a co-formulation that we anticipate will actually be FDA approved later this year. This was actually for 12 weeks of therapy. They enrolled 20 patients in that group. So they also enrolled treatment-naive genotype 1s. These were all mono-infected patients, by the way. We have not actually seen whether 6 weeks of therapy works yet in co-infected patients, but this was a proof of concept in mono-infected patients. So genotype 1 naives received this dual therapy of sofosbuvir, ladipasvir, plus GS9669, which is a non-nucleoside NS5B inhibitor, to 6 weeks of therapy. And then they tried the third arm involved triple therapy with a GS9451, which is a newer generation protease inhibitor. So 20 patients in each arm. These were the patient characteristics. What's a striking feature about a lot of these NIH studies, the NIH SPARE study as well as the NIH SYNERGY study enrolled quite a number of African American patients. You can see that they were comprised the majority of the patients here. More of these patients had genotype 1A. A lot of them had the unfavorable IL-28B genotypes. And you can see here that in the 6-week arms, they made a point of actually excluding folks with cirrhosis. But a substantial minority of these folks actually had stage 3 by Nodell criteria for which is getting up there in terms of fibrosis. And so these were the results. So this was sustained virologic response 12 weeks post-treatment. And basically, we're looking at 100% SVR. You don't really get better than that with the triple therapy arm of sivosavir, ledipasvir, and their newer protease inhibitor. And not only 1% actually didn't achieve an SVR12 in this triple therapy arm of 6 weeks. They basically answered the question that so we've proven the concept that interferon-free therapy is effective in HIV-infected patients with SVR rates similar to mono-infected patients, and that a multi-mechanism combination using the same principles that we use for HIV therapy may allow duration as short as 6 weeks. I think it begs the question of, well, what can we use for interferon-free therapy now? Should we be using dual therapy with sivosavir ribavirin? I would say that sivosavir ribavirin should really be considered perhaps not the optimal therapy. In a lot of my patients who want interferon-free therapy, I'm really waiting for sivosavir ledipasvir. And ION-4 is the study that examines this dual kind of the NS5B and NS5A inhibitor combination in co-infected patients, and they have submitted as of February for FDA approval. This is the data in mono-infected patients. You can see we're seeing SVR12 rates of 98, on the order of 97-98%, and it doesn't seem to matter whether you have ribavirin in the mix or not. This is in genotype 1 mono-infected patients. So David Spock asked me to kind of put a mention of the fact that, one of the challenges, and this certainly came up in this the CROI session, is that these drugs are very costly. And you guys might have seen this recent article of, Congress is actually asking Gilead to explain why they're charging so much, particularly if you consider the fact that the vast majority of hepatitis C patients out there are really rely on publicly funded healthcare. So I haven't heard what Gilead's reply to this query was, but this is certainly a big concern for those of us who treat hepatitis C. I don't know if some of you guys out there have been having difficulty getting drug authorization, but drug authorization is taking up a lot of our clinic's time. And our hope is that once the field becomes a little bit more replete with competitors and different options, that the price tag will come down. But we may be a year out from that at this point. If there's some time, I did want to go over a few other abstracts that I thought was interesting. Because we're in this era where we've got very pricey therapy and limited resources, one of the obvious questions is, we're getting to a point where it's getting crystallized what we should be treating with. But the question is, who should we be treating? Who should we be targeting? And I think there is still a role for risk stratification in terms of identifying those most in need of hepatitis C therapy and where we can target our efforts. So what's interesting was that there were two abstracts that looked at the question of using FIV4 as an outcome. So we're certainly in our clinic, we're kind of moving away from doing a lot of liver biopsies. It's not popular, certainly among our patients, because it is an invasive procedure. This group from Spain looked at FIV4, which was published in 2006 as a simple, easy-to-use, non-invasive index that uses kind of readily available lab parameters. In this case, they use AST platelets and ALT, as well as include age in the mix. And so the cutoff for sort of a high FIV4 is 3.25. And so they used this cutoff and compared it with looking at liver biopsy as a cutoff using fibrosis stage 3, MEDAVIR F3. And it turned out that it actually was a better predictor of both the outcome of death and liver-related events than liver biopsy, which is interesting. I was wondering if it got at some clinical parameters that might predict these, that liver biopsy doesn't. Liver biopsy is also hampered by the fact that we run into undersampling and potentially understaging. I've certainly run into that in a few of my patients. So this was very interesting data. And just in case you thought that was specific to Spain, it turns out they also found this to be the case in the VA aging cohort study. So Vin Larray presented this data in the poster where they looked at the FIV4 score and found that a FIV4 score of greater than 3.25 did predict better than other sort of clinical parameters whether you're going to be likely to go on to end-stage liver disease. I just wanted to leave you guys with this final snapshot of that I took of one of the posters looking at the treatment cascade. Just the same way we have an HIV treatment cascade, there is a hepatitis C treatment cascade, and you can see here that we can be doing a lot better. There's a big drop-off when you consider the burden of chronic hepatitis C infection. Certainly in terms of the percentage of folks who are diagnosed and aware, and then accessing care. I think in terms of the 16%, those who are prescribed Hep C treatment, the hope is that, you know, with interferon-free therapy, this should go up, hopefully, as all of these also should go up. And potentially, we may be doing less of liver biopsy, especially if cirrhosis is looking like less of a key clinical feature in terms of blunted treatment response. I think it's still important to sort out who has cirrhosis, because certainly we're going to be managing those folks differently and screening for HCC. But I thought this was a very sobering reminder that we can be doing better as far as Hep C therapy goes.